Good day, students. This is a lecture on the abnormal X-ray, ultrasound, CT scan, and MRI imaging findings of the genitourinary tract. The objectives for this lecture would be to know the multimodality imaging findings of selected congenital urinary tract anomalies. The second objective is to know the multimodality imaging findings of benign GUT diseases. And last is to know the multimodality imaging findings of malignant genital urinary tract diseases. We will tackle first the congenital renal anomalies. Congenital renal anomalies can be further subdivided into anomalies in number, anomalies in size and form, anomalies in form, and anomalies in position. We will also be discussing the most commonly encountered normal variants in the genitourinary tract. For anomalies in number, the first that we would be discussing would be the renal agenesis. Renal agenesis is defined as a kidney that had failed to develop. There are two subtypes for renal agenesis, the unilateral and the bilateral. Unilateral renal agenesis is compatible with life, and usually patients with this condition are asymptomatic. By imaging, there would be the absence of a renal shadow on one side with an unusually large kidney on the other side. On the other hand, bilateral renal agenesis is usually not compatible with life, as seen in the Potter syndrome, which you would be familiar with in pediatrics. Other associated anomalies would be trisomy 21, Turner syndrome, Factor L, and other congenital heart diseases. This would be an example of the imaging findings in renal agenesis. The image on your left side would be an abdominal radiograph taken during an IVP procedure wherein iodinated contrast material would be injected into the urinary tract. And as you can see, the contrast material is only seen on the right side, which shows dilatation of its pelvocalyceal system. There is non-visualization of the left kidney in the left hemi-abdominal region. CT scan of the same patient done confirmed the findings seen in IVP wherein there's only the right kidney with absence of the left kidney. Next would be the supernumerary kidney. This is the condition when there is more than two separate kidneys present in a patient, or a horseshoe kidney with an additional kidney. In supernumerary kidney, the anomalous kidney would be usually small and rudimentary in size, while the other kidney that is located on the same side would also be smaller when compared to the normal kidney on the opposite side. Imaging findings for supernumerary kidney. The image on the left side would be an abdominal radiograph taken during an IVP. So for orientation, this would be the right side of the patient and this would be the left side. And as you can see, contrast material flowed into the pelvocalyceal system on the right side and that on the left. However, another pelvocalyceal system is seen inferior to the normally located right kidney. On CT scan, supernumerary kidney would appear as such. This would be the right kidney, and then the new red arrow would point out the left kidney, and another kidney would be located inferior to the normally located left kidney. For anomalies in size, we would discuss first hypoplasia. For hypoplasia, there are two types, congenital hypoplasia and acquired renal atrophy. In congenital hypoplasia, the calyceal system and the renal pelvis would be symmetrically small due to a delayed development of the ureteric bud. In acquired renal atrophy, the calyceal system and the renal pelvis would be normal in size. However, there is an overall decrease in renal size due to a parenchymal deficit due to functional impairment. This is also a result of extensive pyelonephritis or an infarction from occlusive vascular disease, such as those seen in patients with chronic kidney diseases. Compensatory hypertrophy is a condition when one kidney would be called on to perform the function that is normally carried on by two kidneys, and as such, there would be an increase in size in all parts of the visualized kidney, meaning its overall parenchyma as well as that of the pelvocalicial system. This is an example of a patient with renal hypoplasia and compensatory hypertrophy. As you can see, the left kidney, as enclosed by the red rectangle, is enlarged in size when compared to the small right kidney. So the right kidney is the one with renal hypoplasia, while that on the left would be the one that had compensated to function for the two kidneys, and hence is hypertrophied in its appearance. For abnormalities in form, the most commonly encountered would be the horseshoe kidney. This is when the lower pole of both kidney would be fused by a band of soft tissue which is called as the isthmus. During nephrogram phase, this would appear as U-shape or L-shape in configuration. Associated rotational anomaly for horseshoe kidney is that the calyces would be directed backward or posteromedially rather than laterally. On imaging, horseshoe kidney, this would be an abdominal radiograph during IVP, and as you can see, the right renal pelvis is lateral and the left renal pelvis is more anteriorly located. Now, another sign for horseshoe kidney during IVP procedure would be the flower vase sign or flower vase appearance. This would happen when the ureter on each side would cross the isthmus. It would curve first laterally and then go medially as it assumes a more normal course. So these are additional imaging findings for horseshoe kidney. As I have mentioned before, it may present with a U-shaped configuration during the nephrogram phase of IVP. So this would be the right kidney and the left with connection of the lower pole through an isthmus exhibiting the U-shaped configuration. This is a cross-sectional CT scan. And again, to reiterate the findings, the lower pole of the right and then the left kidney connected by an isthmus. For abnormalities in position, the most commonly encountered would be the ectopic kidney. It is a condition wherein there is an abnormal location of one or both kidneys. So this would be an abdominal radiograph during IVP, and as you can see, contrast material flowed into the right pelvocalicial system. However, the left pelvocalicial system is located more inferior than what is expected of its normal location, which is at the same level as that of the right kidney. So this is a CT scan in cross-section, and as you can see, the kidneys must be located at the level of L2 to L4 in normal adults, but for this patient, the kidney is located in the pelvic region. For the normal variants, two commonly encountered would be the hypertrophied column of BERTIN and the dromedary hump. I would like to discuss these two because they are usually encountered in clinical practice and might be mistaken for a renal mass. For hypertrophied column of BERTIN, it would only represent an unresorbed polar parenchyma from a developing kidney. On ultrasound imaging, hypertrophied column of BERTIN is usually located at the junction of the upper and middle third of the kidney, and it would always contain the renal cortex that is continuous with the adjacent renal cortex and would usually measure about less than 3 cm in diameter. Hypertrophied column of BERTIN is differentiated from a mass lesion because of the presence of the renal cortex, and it may also indent on the renal sinus itself. On CT scan, hypertrophied column of BERTIN would appear as a well-defined area of enhancement that would show equilibration with the rest of the renal parenchyma in post-contrast scan. So as a series of images shown on the right side, this would be the suspected mass lesion. However, upon introduction of contrast material, this showed an area of enhancement that is similar to the rest of the kidney, so it would denote that this is only a hypertrophied column of BERTIN. If this was a mass lesion that would indicate carcinoma, this would show heterogeneous enhancement and would not equilibrate with the rest of the renal parenchyma. The next normal variant is the dromedary hump or splenic bump. It is a prominent focal bulge seen at the lateral border of the left kidney by imaging. This would happen due to the impression of the overlying spleen at the superolateral border of the left kidney. So on ultrasound, this is the spleen, this is the left kidney, and due to the close relationship between the spleen and the left kidney, you would see that there appears to be a focal bulge at the lateral aspect of the left kidney, and this might be misinterpreted as a renal mass. On CT scan, similar to the ultrasound finding, the spleen and the left kidney with a focal bulge that would happen because of the close indentation of the spleen at its superolateral aspect. So we have already discussed the selected congenital urinary tract anomalies. We will now proceed with the benign GUT diseases. For the benign GUT diseases, I have further subdivided this into lithiasis and calcifications, hydronephrosis, infections and its related condition, and the benign renal mass. For nephrolithiasis, or kidney stones, or renal stones, this would refer to the presence of calculi in the renal collecting system. Most patients with this disease would have a common complaint of lung pain, and complications for untreated nephrolithiasis would include renal or ureteral obstruction, ureteral stricture formation, chronic renal infection, and the most severe complication would be the total or partial loss of renal function. On imaging, for X-ray, nephrolithiasis would appear as a radio opacity that is identified within the renal shadow. So as shown in this radiograph, this would be the right renal shadow, and then the left renal shadow, and as you can see, an radio opacity is seen in the left renal shadow. On ultrasound, nephrolithiasis is seen as an echogenic focus with posterior shadowing. As pointed out by the red arrow, this is the echogenic focus that would exhibit the posterior shadowing, and this is seen within the collecting system of the kidney. On CT scan, nephrolithiasis would be appreciated as a round or oval high attenuation focus within the calyceal or collecting system. As pointed out by the two red arrows, this would be the round or oval high attenuation foci that is seen in both kidneys for this patient. In lithiasis, there is also another type known as the Staghorn calculus. Staghorn calculus is usually formed in the presence of infection and an alkaline urine. And usually, these stones would contain struvite, which is composed of magnesium, ammonium, and phosphate. On imaging, Staghorn calculus would appear as an echogenic focus. This would be the echogenic focus seen by ultrasound with marked posterior shadowing, and this would be noted to conform to the shape of the renal pelvis. On CT scan, Staghorn calculus would appear as a high attenuation focus that would conform to the renal pelvis as pointed out by the red arrow in the left kidney. The next type of lithiasis is the ureterolithiasis or ureteral stone. On imaging, for X-ray as shown in this image, there is a faint opacity located at the right paravertebral region at the lumbar level. This is the expected course for the ureter. Most ureteral stones are identified at the ureteropelvic junction and the ureterovesical junction. By ultrasound, this would appear as an echogenic focus as being pointed out by the red arrow in the proximal ureter. For this patient, there is also secondary hydronephrosis and hydroureter due to the obstructing ureteral stone. In CT scan, ureterolithiasis, similarly to the previously discussed nephrolithiasis and Staghorn calculus, would appear as a high attenuating focus as pointed out by the red arrow in the ureter. There is also secondary dilatation of the pelvocalicial system and hydroureter, as shown. The next type of lithiasis is the cystolithiasis or bladder stone. On imaging by ultrasound, it would appear as a mobile echogenic focus with or without shadowing within the bladder lumen. As shown in the image on the right side and being pointed out by the white arrow, this is the echogenic focus within the bladder lumen. And usually for patients, we would ask them to lie on the lateral decubitus position to confirm its mobility. By X-ray, usually cystolithiasis would appear as a lamellated round calcific density that is at the region of the urinary bladder or at the pelvic area. By CT scan, cystolithiasis is seen again as a high attenuation focus similar to the previously discussed types of lithiasis, and usually this high attenuating focus is located at the bladder floor or at the dependent portion of the urinary bladder lumen. Sometimes, if these cystolithiasis are too small or sub-centimeter in size and are usually located at the ureterovesical junction, in order to confirm whether it is a ureteral stone or cystolithiasis, we would scan the patient in the prone position. And if this lithiasis would move, then it is classified as a bladder stone. But if it does not change in position, then it is classified as a ureteral stone, specifically at the ureterovesical junction. This table provides a summary of the different types of stones or lithiasis that can be identified by both X-ray and CT scan. And highlighted in blue, calcium calculi or calcium oxalate and struvite calculi are the two types of stones that can be seen by the two imaging modalities. But CT scan is more superior than X-ray in identifying the other types of lithiasis such as the cysteine, uric acid, and xanthine calculi. Nephrocalcinosis would refer to the pathologic deposition of calcium in the renal parenchyma. There are two types of nephrocalcinosis, cortical and medullary. Cortical nephrocalcinosis would account to 5% of cases, with causes such as acute cortical necrosis, chronic glomerulonephritis, and primary hyperoxaluria. The more common one and the imaging findings which I would discuss would be the medullary nephrocalcinosis. The medullary nephrocalcinosis usually would result from hypercalcemic or hypercalciuric state, renal tubular acidosis, patients with hyperparathyroidism, or medullary sponge kidney. The X-ray finding for nephrocalcinosis would be there would be dense aggregates of calcification in the medullary region of the kidneys. And nephrocalcinosis is also a systemic disease, hence both kidneys are usually affected. On ultrasound, these would appear as multiple echogenic foci in the region of the renal pyramids with shadowing. On CT scan, nephrocalcinosis would appear as dense calcifications within the renal medulla. So for this patient, as you can see, there are dense aggregates of high attenuating foci in the medullary region of both kidneys. So far, we have already tackled the lithiasis, and we will now proceed with hydronephrosis. Hydronephrosis is defined as the dilatation of the upper urinary tract, and this would happen secondary to obstruction either from a renal stone, renal mass, or intra-abdominal mass that would compress on the urinary tract, presence of pyonephrosis, or for the pediatric patients, vesico-ureteral reflux. On imaging, hydronephrosis is seen as a dilatation of the collecting system, as shown in this image. Hydronephrosis is graded in 1, 2, 3, and 4. For grade 1, the urine would barely split the sinus. For grade 2, there is fullness of the renal pelvis with dilatation of the major calyces. For grade 3, there would already be uniform dilatation of the minor and major calyces but with sparing of the parenchyma. And for grade 4, there would already be parenchymal compromise with marked dilatation of the pelvocalyceal system. This would be an example of grade 1 to 4 of hydronephrosis. As I have mentioned before, grade 1 would be splitting only of the renal sinus. Grade 2, there would already be dilatation of the major calyces. And for grade 3, both the major and the minor calyces would already be dilated, but the parenchyma would be spared. And for grade 4, there would already be parenchymal compromise due to the marked dilatation of the pelvocalyceal system. This is the CT scan image of a patient with hydronephrosis. As you can see, there is marked dilatation of the pelvocalyceal system in the left kidney with evidence of parenchymal compromise. So we can grade this as grade 4 hydronephrosis. While that of the right kidney, the pelvocalyceal system is not dilated. We will now proceed to infections of the genitourinary tract and its related conditions. Acute pyelonephritis is one of the most commonly encountered genitourinary tract infection in clinical practice. This would result from an ascending UTI that is caused by a gram-negative E. coli. And in acute pyelonephritis, CT scan is considered more sensitive than ultrasound in the detection of subtle changes in the renal parenchyma. Imaging findings of acute pyelonephritis in ultrasound would include renal enlargement, decreased echogenicity due to edema, or increased echogenicity of the involved renal parenchyma due to the presence of hemorrhage and loss of corticomedullary differentiation. As shown in this image, there is increased echogenicity of the involved parenchyma with loss of corticomedullary differentiation. There is also decreased flow at this region on color Doppler images, as shown on the image on the right side. CT scan findings for acute pyelonephritis would include renal enlargement, decreased or diminished contrast uptake during the nephrogram phase, as shown in this image. The right kidney shows lesser contrast uptake when compared to the left kidney. There's also distortion and attenuation of the involved calyces. In some patients, pyelocalcinosis may also be observed. Chronic pyelonephritis is a condition that would result from chronic obstruction, calculi, or VUR in children. The imaging findings for chronic pyelonephritis would include renal cortical atrophy, as pointed out by the red arrow in the left lower image. And another hallmark finding would be focal cortical scar that would overlie a blunted calyx, and for some, an echogenic wedge-shaped scar. Emphysematous pyelonephritis is a condition when there is gas within the renal parenchyma, and CT scan is the best diagnostic imaging modality to detect this condition. For example, if you are the resident on duty at the emergency room and you have a patient with a high index of suspicion as having emphysematous pyelonephritis, please request a contrast-enhanced CT scan immediately, rather than requesting a kidney ultrasound and then a CT scan of the abdomen. Usually, the findings for emphysematous pyelonephritis would include an enlarged distracted renal parenchyma, presence of gas within the renal parenchyma, and fluid collection that may show gas fluid levels. This is a further close-up view of patients with emphysematous pyelonephritis. The image on the left side would show an involved left kidney with presence of gas and gas fluid level and destruction of the left renal parenchyma. The image on the right side and being pointed out by the red arrows is also an involved left kidney with presence of gas and destruction of the renal parenchyma. On plain film of the abdomen, emphysematous pyelonephritis is identified as an enlarged renal shadow with presence of air. So for this patient, as you can see, air is seen within the right renal shadow. The next condition we will be discussing would be renal abscess. This would occur as a complication from trauma, surgery, or as a contiguous spread from other intra-abdominal organs. Ultrasound imaging finding for renal abscess would show that there is a round, thick-walled hypoechoic complex mass, and with or without internal debris and septations. CT scan findings of renal abscess would include an enlarged renal size due to the presence of abscess. On contrast study, a thick irregular enhancing tissue may be seen surrounding the abscess cavity, and as shown in the image on the right side, the left kidney shows a thick irregular enhancing tissue on post-contrast studies. There would also be inflammatory changes in the perinephric space identified as perinephric fat strandings. Another condition would be the perinephric abscess. It is defined as an extension of the renal infection into the perinephric space. On ultrasound, the perinephric abscess would be identified as a hypoechoic complex mass within the perinephric space with or without the presence of internal gas content. And as you can see, the image on the left, the right kidney as labeled, there would be a hypoechoic complex mass located inferior to it. And the image on the right side would show echogenic foci, as pointed out by the yellow arrows, which would be identifying the air that is present in the hypoechoic complex mass. CT scan findings for perinephric abscess would include a loculated fluid collection within the perinephric space. The image on the left side would show an infected left kidney as evidenced by its enlarged size, presence of air, surrounding inflammatory changes. The image on the right side, you would see that there is a loculated fluid collection located inferior to the left kidney with an enhancing rim. So this would represent the perinephric abscess. The next disease we will be discussing would be renal tuberculosis. Usually this may follow from a primary tuberculosis infection by as much as 10 to 15 years. Patients with renal TB may present with asymptomatic hematuria or sterile pyuria. The hallmark imaging findings for renal TB would include parenchymal destruction and cavitary formation, parenchymal masses due to granuloma formation, stricture formation of the collecting system and ureter, as well as presence of dense coarse calcifications. Imaging findings for patients with renal tuberculosis. For the IVP, patients with renal TB may present with stricture formation. As you can see, the right renal pelvis in this area is narrowed when compared to the contralateral side, suggesting fibrosis at the renal pelvic region. There is also irregularity of the calyceal margin. Another finding would be the presence of amorphous dystrophic calcification as seen in the right kidney of this patient. And on ultrasound, one may be able to identify multiple hypoechoic masses within the involved kidney that would represent the granuloma formation that is seen in renal tuberculosis. CT scan imaging findings for renal tuberculosis would include amorphous dystrophic calcification, as being pointed out by the red arrow in the right image. The right kidney would show these calcifications. Another feature that we would be able to identify in the CT scan of patients with renal TB is the presence of fibrosis formation or stricture, as seen at the left mid to distal ureter for this patient. Due to this stricture formation, there is secondary dilatation of the more proximal and the more distal ureter. There is also hydronephrosis of the left kidney. The next infection would be the cystitis. Cystitis is defined as the inflammation of the urinary bladder wall. And usually this would be secondary to an infection such as UTI from drugs, radiation therapy for patients undergoing brachytherapy for the pelvic region or prostate carcinoma, and autoimmune diseases. The ultrasound imaging finding for patients with cystitis would be a thickened urinary bladder wall. Also, one may be able to identify sediments within the bladder lumen, and usually these sediments are mobile, wherein when the patient would be asked to change position from supine to lateral decubitus, you would be able to see that these internal debris or sediments would also move when the patient changes in position. Emphysematous cystitis is a form of bladder infection wherein there is gas within the bladder wall. And this condition is associated in patients with uncontrolled diabetes mellitus, chronic bladder outlet obstruction, or an ascending infection from E. coli. So imaging finding, similar to emphysematous pyelonephritis, air is identified. But in this case, it would be within the bladder wall. And as shown in the image on the right side, there are lucencies that appears to outline the urinary bladder, which would signify emphysematous cystitis. On ultrasound, this air within the urinary bladder wall would be identified as the echogenic foci with dirty shadowing, as seen on the image on the left side. The image on the right side would be a cross-sectional CT scan of the pelvic region, and as you can see, lucencies are surrounding the urinary bladder wall. All of these are findings for emphysematous cystitis. We have now discussed the lithiasis, hydronephrosis, and infections, and we will now proceed with the benign renal mass. For the benign renal mass, I will be discussing the renal cyst and the angiomyolipoma. For the renal cyst on imaging by ultrasound would appear as anechoic to a hypoechoic focus. By CT scan, it would be hypodense, and on MRI, renal cyst would appear hypointense in T1 weighted image and hyperintense in T2 weighted image, signifying its water content. Renal cysts are classified by the BOSNIAK classification. This is a classification system used in order to predict the risk of malignancy in a cystic mass, and it would also suggest whether a follow-up imaging is needed or immediate treatment. However, BOSNIAK classification is applicable only for patients that had undergone contrast-enhanced CT scan. Class 1, or the simple cyst, would have a round, thin, imperceptible wall with anechoic or hypodense internal echoes. Class 2 would be the minimally complex, and its features would include a single thin septation and thin calcification. Class 2F would be the minimally complex that would need follow-up, and its difference with Class 2 is that there are thick calcifications present. Class 3, or the indeterminate lesions, would have thick or multiple septations and a mural nodule. Class 4 would be the malignant lesions, wherein a solid mass with or without cystic spaces would be seen, and the treatment is usually a partial or total nephrectomy. This is a diagrammatic representation of the BOSNIAK classification system. BOSNIAK type 1 on imaging. This is the ultrasound image of a lesion that can be classified as BOSNIAK type 1. It is round with anechoic echoes and a thin imperceptible wall. On CT scan, it is hypodense, which would indicate its fluid content with a thin imperceptible wall. And the third image would be an MRI wherein it is T2 weighted bright that would also signify its water content. BOSNIAK type 2 would have a thin calcification present as seen in this image. It is a cyst with thin septation and thin calcification. In BOSNIAK type 3, it is a cyst with thick calcification and mural nodule. As shown in this image and being pointed out by the red arrow, thick calcifications are identified within the cyst with a mural nodule. BOSNIAK type 4, for this patient, the image on the left side, the left kidney would show a renal mass with a thickened wall, and there's also a focal enhancing nodule noted at its medial aspect. We can classify this as BOSNIAK type 4 due to the presence of these imaging features. The image on the right side, we would be able to appreciate a mass at the right kidney with a heterogeneous enhancement in post-contrast studies. There's also no significant inflammatory changes that would suggest an infectious entity. And with this feature, we should have a high index of suspicion that this mass might be a malignant entity. We would now be discussing the angiomyolipoma. Renal angiomyolipoma is the most common benign renal neoplasm. It is a fat-containing lesion that is located at the renal cortex. On ultrasound, as shown by the red arrow at the right side image, a hyperechoic nodule is seen at the renal cortex. CT scan finding of renal angiomyolipoma would be a hypodense fat attenuating nodule located at the cortex. As shown in the images below, a hypodense nodule is seen at the right kidney, and this is attenuation value of fat. Renal angiomyolipoma is of importance because sometimes it is misdiagnosed as renal malignancy, and sometimes biopsies are done in order to confirm its benign nature. Renal angiomyolipoma as well, when they are multiple, is part of syndrome such as the tuberous sclerosis. I would also like to discuss BPH or benign prostatic hypertrophy. This condition is common in male patients, age 50 and above. This would happen when the transition zone of the prostate gland would become enlarged and heterogeneous. This would lead to compression of the urethra. This is also the reason why the most common complaints of patients with this condition would be dribbling of urine, increased urinary frequency, or an incomplete emptying of the urinary bladder. The ultrasound and CT scan finding for BPH would be an overall enlargement of the prostate gland of more than 30 grams. As shown in this image, ultrasound of the prostate gland, it is enlarged with heterogeneous parenchyma. There may or may not be bladder floor extension, and in some patients, you would also be able to identify parenchymal calcifications or concretions. This image is a CT scan of the prostate gland that is also enlarged. We will now proceed with the discussion for the multimodality imaging findings of malignant genitourinary tract diseases. And I will be focusing the discussion to the most commonly encountered malignant GUT diseases, which is the renal cell carcinoma, transitional cell carcinoma, and prostate carcinoma. Renal cell carcinoma would account for 85% of all renal neoplasms. They are more commonly identified in men rather than women. By plain film, kidney with a renal cell carcinoma may appear enlarged with or without distortion of the renal border. On ultrasound, renal cell carcinoma may be a solid or partially cystic mass. It may appear hyper, iso, or hypoechoic to the surrounding renal parenchyma. The image on the right side, and being pointed out by the red arrow, would be a heterogeneous, predominantly hypoechoic mass located at the inferior pole of the involved kidney. CT findings for renal cell carcinoma would include a heterogeneously enhancing mass with possible intralesional areas of non-enhancement that would indicate the presence of necrosis. As shown on the image on the right side and being indicated by the red arrow, a heterogeneously enhancing mass is seen at the superior pole of the right kidney with central areas of non-enhancement. CT scan is also important in patients with RCC as it is indicated for proper tumor staging and evaluation. Also, the detection of venous invasion is important for the surgical planning of the urologist. Next would be the transitional cell carcinoma. It would account for 85 to 90% of uroepithelial tumors, and this transitional cell carcinoma would usually appear as an exophytic polypoid mass and is attached to the mucosa by a stalk. On ultrasound, the tumor may appear as a hypoechoic mass within the renal sinus as shown in the image on the right side, and hydronephrosis may even be noted in some cases. The CT finding for transitional cell would be a tumor would be appreciated within the collecting system. As indicated by the red arrow, a heterogeneous enhancing mass is seen at the region of the left renal pelvis. The tumors in the ureter may also demonstrate the champagne glass sign wherein there would be ureteral dilatation distal to the filling defect. as shown by the red arrow. And last, the prostate carcinoma. This is the third leading cause of cancer death in men, and most of these tumors are adenocarcinomas. Prostate carcinoma may spread by local extension from the lymphatic vessels to the regional lymph nodes or by hematogenous dissemination. The CT findings for prostate carcinoma is limited only to the detection of lymph nodes and the distant spread of tumor to the liver or other intra-abdominal organs. It cannot differentiate prostate carcinoma from BPH. Prostate carcinoma on CT would be appreciated as a heterogeneously enhancing lesion in the peripheral zone. MRI is considered better than CT scan in the detection of prostatic carcinoma by imaging because of better delineation of the soft tissue anatomy at the pelvic region with that of the prostate gland, as well as the anatomy of the prostate gland is better exhibited due to the water content of the prostate gland in MRI. MRI findings of prostatic carcinoma would be an iso-intense nodule within the prostatic tissue on T1 weighted images, and on T2 weighted images, these tumors may appear as areas of low signal or hypointensity within the normally high signal peripheral zone. As shown on the images on the right side and pointed by the red arrows, an area of hypointensity is seen at the peripheral zone. So we have tackled the multimodality imaging findings for selected congenital urinary tract anomalies, benign and malignant GUT diseases. This would end my lecture. Thank you.